So today we'll be discussing about the pelvic inflammatory disease. Do you have any idea what is pelvic inflammatory disease? So you can unmute and you can say. Anyone? Okay, no worries. So today we will be discussing about what is pelvic inflammatory disease. Okay, then what is the likely etiology, mode of infection, what are the risk factor, which follows the pathogenesis, clinical feature, investigation, and then we'll conclude with the management. Okay, so basically pelvic inflammatory disease is a upper genital tract infection, okay, which involves endometrium, okay, tubes, ovaries, as well as pelvic peritoneum. So it's an upper genital tract infection, and the patient usually present with systemic feature. In contrast to the vulvovaginitis, it is a local infection and there is no systemic feature. Okay, so let's start. So it is a spectrum of inflammatory disorder of upper genital tract. Okay, so remember here the buzzword is upper genital tract. Okay, because in vulvovaginitis it involves the lower genital tract. That includes vulvitis, okay, the external vulva, external genital, that is vulva, vagina, as well as ectocervix. In case of pelvic inflammatory disease, it involves the upper genital tract, okay, which includes any of endometritis, salpingitis, tubo-ovarian abscess, or pelvic peritonitis. Okay, in some book you can also get endocervicitis as well. Okay, ectocervicitis is not a pelvic inflammatory disease. It is just a some usually add vulvovaginitis, even in the lower genital tract infection, ectocervicitis. Okay, but endocervicitis, it is a part of pelvic inflammatory disease. Okay, and most of the pelvic inflammatory disease, they are sexually transmitted infection, except genital tuberculosis. Okay, or some following instrumentation. Okay, apart from that, majority it is a sexually shared infection. Okay, so what is the etiology? Most of the cases, they are infected by a combination of organisms, polymicrobial, okay, which can be either gram-positive, negative, or anaerobes. Okay, so 85% they are occurring naturally occurring infections, but 15% they occur by the breach in the cervical mucus barrier. Especially there is some variation in the cervical mucus barrier during menstruation or following some instrumentation, like when we do some endometrial biopsy. Okay, on HSC, like any invasive procedure. In that case, there could be breach in the cervical mucus barrier as well. Okay, so what are the common organisms? Though we know it is a polymicrobial organism, but common are chlamydia, which is the most common cause of the pelvic inflammatory disease, which follows Neisseria gonorrhea. Okay, these two, okay, Neisseria gonorrhea and the chlamydia, they often coexist and they contribute almost 70-80% of the cases of pelvic inflammatory disease. Okay, others now the emerging, okay, the mycoplasma is emerging. It's nowadays it's more common, so the more and more cases of the pelvic inflammatory disease with mycoplasma, okay, they are detected nowadays. Okay, and other secondary infection, which includes organisms, includes Escherichia coli, okay, E. coli, Klebsiella, anaerobes. Okay, and there is a special organism, okay, this is Actinomyces israeli. So this is a gram-positive anaerobe. Usually it is associated with pelvic inflammatory disease with copperty in situ, okay, usually within 10 days of insertion. Okay, so to remember, some most common organisms includes chlamydia and Neisseria. If IUD in situ, always think of Actinomyces israeli. Okay, we discussed about the organisms, so now let's talk about briefly about the mode of infection. So commonest, as we know, it is a sexually shared infection. There are a few exceptions. Apart from that, it is a sexually shared infection or sexually transmitted infection. So this is the most common route. Other include like following any invasive procedure, okay, or following abortion, in post-abortal, which is common after septic abortion, okay, post-surgical or any post-procedure like endometrial biopsy, dilatation and curettage, okay, copperty insertion, intrauterine sort of contraceptive device like copperty, Mirena, okay, hormone or hormone medicated copperty or normal copperty, okay, that is what we call copperty 380A. Okay, so any invasive procedure or surgical procedure, it can follow pelvic inflammatory disease if we do not follow the strict septic precaution. And other include infection from other side, okay, like hematogenous or lymphatic spread. And puparium, okay, during puparium there could be infection of endometrium, okay, parametrium, as well as okay, even tubes and pelvic peritoneum. But we usually say puperal sepsis in those cases, okay. We do not say pelvic inflammatory disease, but in fact it is a pelvic inflammatory disease. But in puperal cases we say puperal sepsis, which we have already covered in our previous lecture, okay. So let's talk about some risk factor. Okay, we know it is a sexually shared infection. That's why so multiple sexual partner is a common risk factor. Non-use the barrier method of contraception. Okay, so barrier method of contraception is very effective in prevention of pelvic inflammatory disease. Okay, so when there is non-use of barrier method, obviously it will be a risk for pelvic inflammatory disease. Concurrent gonorrhea and chlamydia infection in both partner, male or female. Okay, it can cause pelvic inflammatory disease, prior history of pelvic inflammatory disease, immunosuppression. Okay, the patient taking an immunosuppression, such as the patient with a kidney transplant or maybe HIV patient. Okay, so these patients are vulnerable for pelvic inflammatory disease. And recent instrumentation, okay, or surgery, such as endometrial biopsy, intrauterine device placement, hysteroscopy, and hysterosalpingogram. Okay, so am I clear so far?
Yes, sir.
Okay, so now let's discuss about the pathogenesis, how it occurs. Okay, so we discuss about organisms, what are the common organisms, okay, and what is the mode of transmission. Now let's discuss briefly about the pathogenesis. Okay, so one route is direct or canalicular spread. That means canal. Okay, it's spread from the canal. That means from, okay, vulva, vagina, the organism enters, okay, then it enters the cervix, then goes to the endometrium and tubes, and finally to the pelvic peritoneum. This is the canalicular spread. Okay, so you can see here, okay, so directly canalicular spread. This is the most common route of pathogenesis, okay, commonly involved route. The other are non-canalicular spread like hematogenous or parametrial lymphatics, okay, or lymphatic spread. That is less common. So pathway of action is cervix. Okay, so initially cervicitis, endometritis, salpingitis, uveitis, and it becomes tubo-ovarian abscess. Okay, tubes and ovary, they get clumped with the inflammatory exudates and form a mass, what we call tubo-ovarian mass. Okay, and finally peritonitis. So this is the pathway of ascent. So like we discussed about the contributing factors like uterine instrumentation, hormonal changes during the menstruation. Okay, so because there is an alteration in the cervical mucus, and cervical mucus, it has a role in, one is barrier. Okay, so it acts as a barrier against the organism, okay, as well as it has a bacteriostatic effect. Okay, other contributed factor includes the retrograde menstruation. So menstrual blood, it can regurgitate back into the tubes. Okay, so and these blood, infected blood, sometimes it can carry the organisms. Okay, the blood which can carry the organisms, it is regurgitated back into the tubes and pelvic peritoneum ovary. Okay, where it can flourish. Okay, in the favorable environment. Another is the virulence of the individual organisms. Okay, so these are the factors which contributes to the pathogenesis. Okay, so remember, the most of the cases usually they have primary site of infection. Okay, so there is certain initial, there is a colonization of the bacteria in certain glands. Okay, so the primary site of infection could be, so this is the in the urethra. Okay, so there are glands in the urethra, what we call skin glands. Okay, paraurethral glands, skin gland. So other reservoir, okay, other primary site of infection includes Bartholin gland. Okay, so Bartholin gland, skin gland or paraurethral gland, and in cervix as well. Okay, so cervical gland. So from here the bacteria start colonizing and they get flourish and they get ascend. Then finally subsequent site of infection includes tubes. Okay, what we call salpingitis, and the tube get hyperemic. There will be collection of the pus. Okay, you can see the pus draining from the tubes, and it can involve tubes, ovary, okay, uveitis, and finally pelvic peritoneum Okay, that is peritonitis. Okay, so this is how they pelvic disease process ascend. Okay. Okay, now let's discuss briefly about the pathological anatomy. So what will happen in case of acute pelvic inflammatory disease? So remember, pelvic inflammatory disease is usually a bilateral disease. Okay, so there is usually both tubes are affected. Okay, and it becomes swollen erythematous. Okay, lumen becomes distended with the blood and necrotic materials. Pus trickles down from the ostium, and there will be minimal adhesions may be present. Okay, so in acute, there is acute reaction. Okay, acute inflammatory signs could be appreciated, but in case of chronic, there will be reactive changes. Okay, so initial self-anxieties, there could be after initial self-anxieties, there could be residual disease. Okay, especially if the patient do not get any treatment or if there is a partial treatment, and it can be invaded by the secondary invaders. Okay, then there will be secondary exacerbation. Okay, on and off, she can have secondary exacerbation which can occlude the tubes. Okay, the femoral end of the tubes. Then after the occlusion, there will be grossly distension of the tubes, what we call hydrosalpinx, or if it is filled by the pus, otherwise we call it pyosalpinx. Okay, peritubular adhesions. Okay, now in case of chronic, there will be more reactive changes. Okay, with the fibrosis, there will be adhesions. Okay, there is a clumping of the tubes, ovary, leading to tiomas. Okay, and there is a condition where there is a chronic inflammation in the retroperitoneum. Okay, so in the retroperitoneum, by maybe through the parametrium, the infection, it gets spread to the retroperitoneum involving the ureter, leading to uretral obstruction, what we call ligneous seroditis. Okay, so this is about the pathogenesis. Okay, so let's discuss about the clinical feature. Okay, so how the patient will present in the OPD or at times in accident and emergency. Okay, so how the patient usually presents? Okay, usually patient present with a acute abdomen. Okay, so lower abdominal pain if it's in case of the emergency, or in case of OPD, just lower abdominal pain. Okay, that is a common presenting feature even in the OPD cases as well as in the emergency. Okay, other includes pelvic pain, deep seated pain. Okay, purulent vaginal discharge, this is also very common. Okay, so in 90 out of 100 cases, the patient usually have lower abdominal pain, and around 75 out of 100 to complain of purulent vaginal discharge. Deep dyspnea. Okay, so difficult in sexual intercourse, painful sexual intercourse, especially deep. Okay, deep dyspnea is common in case of pelvic inflammatory disease. All the systemic feature. Okay, remember in vulvovaginitis, lower genital tract infection, there is no systemic feature. Okay, so here there is a systemic feature like fever, chills, nausea, vomiting. Okay, on examination you can appreciate some temperature. Okay, abdominal tenderness in the lower quadrants, rebound tenderness if there is pelvic peritonitis, if there is peritonitis, mucopurulent discharge, cervical motion tenderness, adnexal tenderness, or obvious mass could be appreciated as well. Okay, so what is the proportion of severity? According to the severity, usually majority of the cases, almost 2/3 of the patient, they come as a subclinical PID. Okay, mild lower abdominal pain. Okay, so usually subclinically. Okay, so they could be missed and there could be sequelae in as high as 60% of the cases. That's why we should have a very low threshold for treatment, especially the patient is young, sexually active, less than 25 years. Okay, then another third, they come with a overt pelvic inflammatory disease, but the features are usually mild to moderate. Okay, severe PID you can appreciate only in the 4 out of 100 cases. Okay, so let's discuss about the workup. So what we can do if you suspect the patient with a pelvic inflammatory disease, okay, we run some tests like complete blood count, mainly total count, differential count, but they are not very specific. Okay, so only in less than 50 out of 100 cases you can appreciate the rise in the counts. Other includes erythrocyte segmentation rate. It is increased almost in 70 out of 100 cases, but they are also not that specific. Okay, now PPI cases. Other plasma protein, which are aqueous phase reactant like C-reactive protein, anti-chymotrypsin. Okay, so though these are more sensitive than ESR, but still they lack accuracy. Okay, so blood test to rule out other infections like HIV. Okay, and syphilis like VDRL. These tests should be done. Okay, so because this is the sexually shared infection, that's why we have to rule out other sexually shared infection as well. Okay, and investigation available to diagnose the PID lack accuracy. So this is the problem. That's why, you know, high index of clinical suspicion is the one. Okay, that's why you should have a high index of clinical suspicion. So you diagnose with a clinically most of the cases. Okay, because the blood parameters, they usually lack accuracy. Okay, so blood tests such as total count, differential count, erythrocyte segmentation rate, C-reactive protein, all these are non-specific. Okay, they may be elevated in the pelvic inflammatory disease, but in mild cases it can be normal. Okay, so even in the mild cases it can be normal, but remember, even in the mild cases there could be sequelae, and the sequelae is not good. Okay, the patient may complain of, may in a later life they can develop chronic pelvic pain, ectopic pregnancy. Okay, so so the sequel is not good. So that's why even in the mild cases we have to do a full treatment. Okay, so there are other investigation as well which will help in diagnosis. So one is the blood test. So in blood test commonly we send total and differential count, ESR and CRP. Okay, and other STI like VDRL and HIV. In microbiology, we take swabs, a number of swabs. Okay, so intracervical swabs, urethral or high and low vaginal swabs. Okay, and pus collected from the fallopian tube if the patient underwent laparoscopy or laparotomy. Okay, in that case, we can collect the pus and send for culture and sensitivity. Okay, so if we isolate the gonococcal infection, so what will be? Okay, in case of gram stain, they are gram-negative diplococci. Okay, so remember these are the gram-negative diplococci. So we can culture them in is chocolate agar or Thea Martin agar. Other tests include fluorescent antibody staining, nucleic acid amplification tests. These are like a PCR, okay, polymerase chain reaction, similar. Okay, these are very sensitive culture. Rapid tests include ELISA and DNA probe are also there. Okay, this regarding the gonococcal infection. And remember, the gonococcal infection, they are more symptomatic. Okay, these patients are more symptomatic, acute. They present with a acutely. Okay, usually in short duration they present coffee's discharge and systemically unwell. Okay, but another common organism what I've already discussed is the chlamydial infection. Okay, chlamydia trachomatis. Here the patient usually present late because not all cases are symptomatic. Okay, but the sequelae is not good. Okay, the sequelae is bad in both of the cases with gonorrhea as well as chlamydia. And another is furthermore both. Okay, most of the cases they are infected with the both chlamydia as well as gonorrhea. Okay, so how to isolate the chlamydia? So these are intracellular obligate parasite. Okay, so bacteria. So they are gram negative. That's why we use special stain, gemcitabine for them. Okay, a cell culture like HeLa cell, special cell culture, HeLa cell culture treated with the cycloheximide. Other tests include fluorescent antibody stain, ELISA, PCR, okay, or NAT. So latest is the NAT, that is nucleic acid amplification test. Okay, so it is highly sensitive, almost 85%, and it is highly specific. Okay, so these chlamydial cells, okay, these are the elementary body. So infective part of the chlamydia is elementary body. They get attached to the cells, and now they convert into inclusion. And within the inclusion, they divides to form the reticulate body. And the reticulate body, okay, they will divide. Okay, so they divide and then again convert into the elementary body over the 36 to 48 hours, and around 48 to 72 hours they get lysis and extrusion and infect the other cells. Okay, so this is how the chlamydia infect the cells. So am I clear so far? Are you audible? Am I audible? So is there any disturbance?
No, sir.
Okay, so let's continue. So coming to the investigation, another one. Okay, so we discuss about the blood test, we discuss about the microbiology swabs, okay, and some PCR, nucleic acid amplification test as well. So now, so I have kept this laparoscopy in the investigation because we can use, okay, when there is a diagnostic dilemma, in that case we can go for diagnostic laparoscopy. Okay, so basically it is a direct visualization of the cavity, okay, abdominal cavity and the pelvis. So that's why it is a gold standard for diagnosis. It is strongly indicated in the patient who are not responding to the therapy. Okay, so usually we can treat the patient empirically with antibiotics, and even the patient do not respond within 72 hours. Okay, then we may have to go for laparoscopy. Okay, so why it is needed? To confirm the diagnosis, okay, to rule out the other pathology, okay, to obtain the cultures from pouch of Douglas and tubes, and drain the pus if necessary. Okay, so it helps in assessing the future fertility prognosis as well as planning as well, because when there is a gross distortion of the tubes, less likely the patient will conceive. Okay, so that's why it has prognostic role as well. So you can see the tube. This is the tube, and it is grossly distended. Okay, so grossly distended, hyperemic. So what are the finding in case of laparoscopy? Okay, in pelvic inflammatory disease, if it's a mild case, then there are usually just edema. Okay, so you can see the edematous tube, erythema. Okay, no purulent exudates are mobile, and the tubes are mobile and they are edematous, but there is no pus in case of mild. In moderate, they are not freely mobile and there is pus. Okay, so pus is usually excluding from the tube. So you can see here the pyoshalfings, there is a pus within the cavity, and the pus is emanating from the femoral end of the tubes. Okay, so in pyoshalfings, okay, in severe there is a pyoshalfings. Okay, so this is here we can see pus in the cavity. When there is a pus in the cavity, we call it severe. Okay, so pyoshalfings, inflammatory complex, and abscess. Okay, when there is obvious TO abscess or pyoshalfings, it is a severe. Okay, so we can assess the severity with laparoscopy as well. And in a chlamydial infection, okay, because of reactive changes and fibrosis, you can sometimes you can appreciate the violent string or like adhesions, okay, in the pelvis, especially in the, it's not in the acute cases, but especially in the chronic cases. Okay, in the pelvic and around the liver, what we call Fisz-Hughes-Curtis syndrome. Okay, so you can see the violent like appearance. Okay, these are the adhesions. Okay, so this is Fisz-Hughes-Curtis syndrome. Okay, so apart from the laparoscopy, so we can use some radiological techniques to help diagnosis as well. Okay, so regarding the radiological techniques, which includes ultrasound. Okay, ultrasound, it can be transabdominal or transvaginal. So you can see there is a grossly distended tube. Okay, you can see this is the tube. Now it is a grossly distended. Okay, so distended over its a bit should fill tube. Okay, so this is the hydrosalpinx. Okay, or you can appreciate in pelvic inflammatory disease there is a thickening of the tube. So the tube lining is thickening, the wall of the tube is thickening. Okay, this could be other finding. Okay, there could be presence of free fluid in the peritoneum. Okay, or of abscess. Okay, that both tube ovary get clumped to form the tube abscess. Okay, so rarely it requires the MRI and CT scan. We usually do not do. Okay, because most of the cases they are diagnosed with the USC ultrasound clinical picture or with a laparoscopy. But still, if there is if sonography does not lead to the clear diagnosis, then we can offer MRI or CT. Okay, so in that case you can see there's a lot of pus collection within the tubes, and there is a ovary. You can see the infected ovary as well. Okay, so this is the tube abscess. Now, so what other investigation tool include endometrial biopsy, but we do not do. Okay, we do not commonly do endometrial biopsy. But it provides the confirmatory histological diagnosis. Okay, sorry for disturbance. Okay, so
सर हजुरको म्युट भइरहेको सर
ए ओके यो चाहिँ अगाडिको पार्टहरु अडिबल थियो कुरा सुनेको थियो कि
सुना थियो इन्डोमेट्रियल बायोप्सीमा अब
okay let's discuss briefly about endometrial biopsy. Okay, we do not perform endometrial biopsy, okay, but sometimes when you do the cases surgery in case of pelvic inflammatory disease, we remove the tubes in that tube. Okay, so you can see the inflammatory infiltrates. If it's acute, then you can see a lot of neutrophilic infiltrates, and if it's a chronic inflammation, then plasma cells. Okay, though this is the less expensive, we usually do not do endometrial biopsy for the diagnosis of pelvic inflammatory disease. Okay, other technique is coldocentesis. This also usually we do not do. Okay, because so if we do the purulent, we can aspirate the purulent peritoneal fluid. If the count is more than 30,000, then it is also a diagnosis. Okay, it also helps in the diagnosis of pelvic inflammatory disease. So remember, there are other investigations, so make sure that you screen for the other sexually shared infection, and always rule out pelvic tuberculosis as well. Okay, because this is endemic in our part of the world, and the investigation should be extended to the male partner as well. So male partner, okay, the smears and the culture should be made from the male urethral secretion, so that male partner should be treated. Okay, so now let's discuss about the criteria for pelvic inflammatory disease. Okay, so this is the Center for Disease Control, CDC criteria. So minimum criteria, okay, is clinical abdominal so clinical criteria is lower abdominal pain with uterine or adnexal or cervical motion tenderness, any. Okay, if the patient is complaining of the abdominal pain, and if there is either uterine tenderness or adnexal tenderness or cervical motion tenderness, that is a minimum criteria for pelvic inflammatory disease. Okay, then in that case you can start a treatment. Okay, so other additional criteria includes oral temperature more than 38.3 degrees Celsius centigrade. Okay, abnormal cervical or vaginal mucopurulent discharge, presence of increased WBC, okay, white blood cells on saline amount of vaginal secretion, increase in erythrocyte segmentation rate, and C-reactive protein, lab documentation of infection like nucleic acid amplification test or culture positive Neisseria gonorrhea or chlamydia. Okay, so these are the additional criteria. And definitive criteria, either if there is a histopathological evidence or obvious TOA abscess is diagnosed on the sonography or radiological test, or laparoscopic abnormality, it is consistent with the PID. Okay, so CDC recommends empirical treatment of PID if minimum criteria are met. So remember, we do not need any investigation to treat the patient of PID. Okay, if the patient meet the minimum criteria, that means the patient is having lower abdominal pain with either uterine tenderness or adnexal tenderness or cervical motion tenderness, you can start the treatment straight away. Okay, so what are the differential diagnoses? But you always have to rule out certain differential diagnoses. Okay, so one is acute appendicitis, ruptured ectopic, hemorrhagic cyst. Okay, rupture of the hemorrhagic cyst or torsion or any ovarian accident. Okay, it could be torsion, hemorrhage, or infection of the ovarian cyst. Okay, or endometritis. So these are the common differential diagnoses. And always remember, okay, the sequelae of the pelvic inflammatory disease is so bad. Okay, so it's so depressing. Like the patient can have lifelong chronic pelvic pain. Okay, patient can have ectopic pregnancy or completely infertile as well. Okay, so that's why Okay, so let's start. So the internet is very unstable. So I'm sorry for that. Okay, so let's resume again.
Excuse me, sir.
Remember? Hello?
सर मिनिमम क्राइटेरिया त सर एक्टोपिक प्रेग्नेन्सीसँग पनि रप्चर्ड एक्टोपिक प्रेग्नेन्सीसँग पनि मिल्न गइरहेछ सर अनि त्यसपछि इम्पेरिकल ट्रिटमेन्ट स्टार्ट गर्ने सर त्यसमा नि
मिल्न त गइरहेछ त्यही भएर त डिफरेन्शियल डायग्नोसिसमा राखेको नि हैन that's why in case of ruptured ectopic, okay, ruptured ectopic, there will be urine pregnancy test positive or there is a beta HCG is positive. In case of pelvic inflammatory disease, positive हुन्छ त हुँदैन नि त हैन usually pregnancy मा PID त्यति कमन हुँदैन. Okay, that's why if there is ruptured ectopic, the clinical signs clinically there could be acute abdominal pain, there could be cervical motion tenderness, but urine pregnancy test is positive, and with the help of sonography we can see the free fluid in the pouch of Douglas. Okay, तर पेशेन्टले युजुअली एक्टोपिक प्रेग्नेन्सीको पेशेन्टमा चाहिँ फल स्मेलिङ डिस्चार्ज जनरली एकदमै फिभर त्यस्तो खालको हिस्ट्री चाहिँ हुँदैन. ओके, द्याट्स वाइ एडिसनल क्राइटेरियाहरू हेर्नुपर्ने हुन्छ त्यस्तो केसमा. द्याट्स वाइ आई केप्ट इट इन द डिफरेन्शियल डायग्नोसिस. सो डिफरेन्शियल डायग्नोसिस भनेको सेम मिनिमल क्राइटेरिया सबैमा मिट हुन्छ. That is called differential diagnosis. Okay, so exact this is not a confirmatory diagnosis, but you have to rule